All right, guys. This is Chapter 9 of the EMR course, Patient Assessment. This is one of the most important skills that you have as a medical provider. You need to be a detective, figure out what's going on with this trauma patient or this medical patient, and this chapter is going to give us a way of doing that. It's going to explain systematically. It's going to give us step-by-step instructions on how to get that information. And this is how most everybody does it. When you get up into your EMT assessment, it's almost the exact same thing. When we do our paramedic level assessments, pretty much the exact same thing. With those higher levels of care, they have a few other tools at their disposal, but this is the basic. And like we talked about in some of the earlier chapters, this is how you build on the next level. So let's get going. So our competencies, we're going to use scene information and simple patient assessment finding techniques to identify and manage immediate life threats and injuries within the scope of practice of the emergency medical responder. First step is going to be our scene size up. Scene safety, always 100%. The biggest concern is to make sure that you are safe. Scene management, impact of environment on patient care, addressing hazards, violence, need for additional specialized resources, standard precautions. This is going to be our gloves, our face masks, our gowns, whatever we need. Then we move into our primary assessment, which is assessment for all patient situations. We're going to determine our level of consciousness, check our ABCs, identify life threats, assessment of vital functions. Then we're going to begin interventions as needed to preserve life. Then we got to do history taking, determine chief complaint, mechanism of injury, or the nature of injury, associated signs and symptoms with that. Secondary assessment, performing a rapid full body scan. We're going to focus on assessments of pain, assessments of vital signs, reassess how and when to reassess patients. All right, so EMRs are usually the first trained emergency medical service responders to arrive on most emergency scenes. The initial actions that you guys perform will not only affect you, but the patient and other responders. Your assessment of the scene and patient will affect the level of care requested for the patient. It's important that you're able to perform a systematic approach to your patient assessment and determine whether your patient has a medical condition or has sustained injuries from trauma. Our steps for this is going to be perform the scene size up, perform a primary assessment, obtain patient medical history, perform a secondary assessment, and then perform a reassessment. So the skills and knowledge presented in this chapter follow an assessment-based model. That means that the care that we provide, the treatment rendered, is based on the patient's symptoms. Assessment-based care requires you to conduct a careful and thorough evaluation, and that's what we're going to show you how to do. So this assessment sequence provides a framework that you're able to safely approach an emergency scene, determine the need for additional help, examine the patient, determine if injuries or illness are present, obtain the patient's medical history, and then report those results to other EMS personnel. So our scene size up. General overview of the incident and its surroundings. So this is just giving us an overall idea of what's going on. It begins really with our dispatch information. It's going to give us our location, the main problem or type of incident, an idea of the number of people involved, and any safety issues that might be going on at the scene. It's important to remember that dispatch isn't always going to get the most accurate of information. You have, an accident that just happened. You got people that are adrenaline's pumping. They're trying to phone in and tell dispatch all this information where they might not actually have the most accurate information. So once again, we want to keep reviewing dispatch information, and we need to think about some of the other factors that are going on. What time of day is it? First thing in the morning, middle of the day, late at night. These are all important things to remember. Is it the middle of the day in the summer? It's going to be hot out. If it's at night, you're going to need lights out there. Does that mean that we need to call for some additional resources to get more lights out? What's going on? Day of the week, I guess this could be, when you think of, for rural, the best thing I can think of for this is rural communities. You might not have all the resources you need. If you're a volunteer fire department and this is in the middle of the day, a lot of those volunteers might be out doing their regular job. So do we need to call for additional help from another community? Weather conditions. Like I said, is it hot? Is it freezing cold? What's going on? So we need to mentally prepare for other situations you might find when you arrive on the scene. If you come across a medical emergency, you need to contact dispatch using your two-way radio. That might also need to be a phone, or you might need to send somebody to get help. Ensure scene safety. So this is, as I'm looking at this book, we have a couple of things that I feel kind of out of order. Something that you need to 100% every time is take standard precautions. So yes, scene safety is very important, and it's right up there with these standard precautions. Personally, I feel that you should have at least your basic gloves on every scene you go to, as well as making sure that scene's safe. So we do talk about standard precautions here in a minute, but I think that usually is something that you should already have on and be ready to go. So let's get back to it. Ensure scene safety. Park your vehicle so that it helps secure the scene and minimize traffic blockage. As we arrive on scene, we want to scan the scene and determine the extent of the incident. How big of an incident is this? Any possible number of people injured, and the presence of possible hazards. When we talk about possible hazards, we need to realize that there are both visible and invisible hazards. Visible hazards include crash or crime scenes, fallen electrical wires, traffic, spilled gasoline, unstable buildings or surfaces, weather, crowds. Some invisible hazards. We talked about fallen electrical wires there. Invisible hazards, electricity. Not every line that goes down is shut off. So that car that hit that power pole, dropped that line into the middle of the road, you don't know if that thing's still hot or not. A couple other things: biological hazards, hazardous materials, poisonous fumes. If the scene is unsafe, we need to keep people away until specially trained teams arrive. So when you arrive on scene and you determine that you're going to need additional resources because we have some hazardous material spilled all over the road, you're going to have to wait for those people to get there. And you're going to have to keep other people away from it. This means that people inside that scene might not get the timely care that they need. But once again, you have to keep yourself safe. Don't make yourself a patient. And you also have to keep the other bystanders safe. Don't let them become patients. So the next step in our scene size up is going to be determine the mechanism of injury or nature of illness. We need to look for clues that may indicate how the accident happened. Some examples in our book include a ladder lying on the ground next to a spilled bucket of paint. It's possible that the patient fell from the ladder. We might have injuries from that. If it was a vehicle crash, we need to think about the type of crash. Was it head-on collision? Was it a rollover? These are going to give you different injuries. Now, some of them might be the same, but the type of wreck can help give us an idea what type of injuries we might be seeing. When we get up close, was the steering wheel bent? Is there spidering of the windshield where somebody struck their head? These are more clues to give us an idea of where we need to be looking. With nature of illness, we need to ask the patient, family members, or bystanders for any additional information. And this also goes for mechanism of injury as well, as if it's a trauma or something like that. And then we can't rule out any injury without conducting a full body physical assessment. So just because we see that spidering of the windshield and that's all we see, we still need to we can't just concentrate on checking that patient for a head injury. We need to do a full, thorough assessment of the entire body to give us an idea or to give us more information and rule out some of the other injuries that might have occurred. So here's our take standard precautions. Always have those gloves ready. Consider whether the use of additional protection may be necessary. Do we need to get gowns and eye protection, all that good stuff. And then one of the biggest things to help prevent you from getting sick is always wash your hands after contact with the patient or contaminated materials. Don't work a wreck, with blood and body fluids and vomit everywhere, and then take off and go grab lunch, without washing your hands first. Wash your hands constantly. I'm just you'll hear me say it a lot, but just make sure that we're doing that. All right, next is going to be determine the number of patients. So you guys are the first responders on scene, and you have an ambulance coming. They're going to be a while. You get on scene and you find that you have 4 other patients. That one ambulance is not going to be able to deal with 5 patients. So you need to get on the radio and let somebody know that we're going to need more help. That sometimes it might be necessary to perform triage, which is sorting the patients into groups so that we can determine who needs the most help. We're going to talk about that a little bit later in the book. So, but essentially it's, if you can hear my voice and you can walk, come move over here under this tree. If you can't walk, but you can hear my voice, raise your hand. And that's another group of people. And then if you can hear my voice, so we've ruled out the ones that can walk, the walking wounded. We've ruled out the ones that can't do anything by raising their hand, but they're alert and conscious. Then we need to prioritize the ones that can't hear us at all. And some of those ones might actually be dead on arrival, dead on scene. Again, talking about additional resources, those resources might include law enforcement if if there's an active crime scene going on, if you have violent people in the middle of your scene. Do we need fire department units for hazmat or fire suppression? Utility company personnel, is that power line down on that vehicle and still hot, still live? We don't know. We need to get some utility people out to help with that. And then wrecker operators. Somebody's got to clean these vehicles off the road once we're done here. The next step in our assessment, our patient assessment, is going to be the primary assessment. The purpose of this is to identify and treat any life threats to the patient. Do we need to address the airway? Do we need to address the breathing? Do we need to address circulation? Is something going on that has to be corrected before we can go any further? Do we need to open that airway? Do we need to start breathing for these patients? Does this patient have a major bleed that's, pooling blood all over the floor? Do we need to stop that bleed before we can go any further? That's what the purpose of the primary assessment is. The first step in our primary assessment is to form our general impression. We're going to determine the patient's sex, approximate age. We're going to determine any trauma or illness that the patient has experienced, and we're going to determine the patient's level of consciousness. To do that, we're going to start by introducing ourselves. As we walk on scene, hello, my name's Aaron. I'm with EMS. What's going on today? We're telling them why we're there. We're telling them we're going to be helping them, and this is going to help us determine the patient's level of consciousness. If they respond to us, we obviously know that they are awake and alert, right? We want to do it even with unconscious patients, because they can still hear us. They might appear unconscious, but they're not. They're just not acknowledging other people in the room. So we still want to introduce ourselves. When we introduce ourselves, hopefully they can tell us their name. That's a way of determining the name for when we got to do our paperwork. We have to have a name associated with it. Then we want to continue using that name. Talk to them, help them, put them at ease. Something that we don't want to do is tell them that everything's going to be all right, because we don't necessarily know that. We're doing the best we can, and we're going to be helping them today. To determine our level of responsiveness, we use what's called the AVPU scale. That's awake and alert, alert to verbal stimuli. So we came in, we talked to them, and they responded to us. That means they're awake and they're alert. We came in, we introduced ourselves. They didn't respond to us, but when we loudly said, "Hey, hello," talking to them, they opened their eyes, they woke up. That's alert to verbal stimuli. So we came in, introduced ourselves. They didn't respond. We loudly spoke to them. They didn't respond. So now we're going to apply a little painful stimuli, maybe a little sternal rub or small pinch on the neck. And they open their eyes. Hey, stop that. Quit hurting me. That's alert to painful stimuli. If we did all that, still nothing, this is what we're going to call unresponsive. You guys need to know this AVPU scale. When we do our patient assessment labs, when you guys come in, you will be expected to know this. So there's probably going to be a test on it. Just saying. Small note in our book is that infants and children might not have the verbal skills to answer questions. So when we assess them, generally when we're talking about children, we look at how they interact with the adult, the caregiver in their life. That's a better way of assessing them than trying to talk and get questions out of them. All right, so we formed our general impression. Now we need to perform a rapid exam. This is where we get into our ABCs. I told you guys they'd be coming up quite a lot, and here it is, in the next chapter. First thing we're going to do, assess that airway. If the patient is alert and able to answer question, we can assume that the patient's airway is open. With an unconscious patient, we need to open that airway. With medical patients, we want to make sure that with medical patients, we can use the head tilt, chin lift maneuver. With suspected trauma patients, remember we want to use the jaw thrust. After we get that airway open, we need to inspect it for any foreign bodies or secretions. Clear it as we need to, finger sweeps or suction. And we might need to insert an oral or a nasal airway adjunct. So after airway, we move right on to breathing. We need to assess the rate and quality of the breathing. How fast is it? What type of breathing is it? Is it shallow? Is it irregular? Is it a breath like it's supposed to be every 5 to 6 seconds? That would be regular. Is it a breath and then a big pause and then 2 breaths? What's the quality? Says here, if the patient is unconscious, use the look, listen, and feel approach. So we're going to look at the chest, we're going to listen to the air moving in and out, and we're going to feel for breath on your skin. Once again, if the patient is not breathing, we need to open that airway and perform rescue breathing for him. So after breathing, we have circulation. If the patient is unconscious, you want to check for carotid pulse. That's our pulse here in our neck. If the patient is conscious and we're talking to them, we want to assess the radial pulse in their arm. For children, generally we use the brachial pulse, which is in the upper arm. After we check for pulses, we want to look for any severe external bleeding. So if we have some minor scrapes and cuts on our body, these are not major bleeds and don't need to be addressed right away. If we have squirting blood, if we have large amounts of blood staining their clothing, or we have a large puddle of blood that's just getting bigger, we need to stop that right away. So that would be checking for external bleeding. And to do that, we use a blood sweep. We start at the head, touch the head, look at our gloves. Do we see any blood? Go down the neck, the shoulders, torso, abdomen. We're just every bit we touch, we're looking for blood. Go down the lower extremities, looking for blood. Upper extremities, looking for blood. If we find blood, we want to check it. Is it major? Is it not? The next step is going to be assess the patient's skin color, temp, and condition. So, is it normal? Is it pale? Is it flushed? Is it cyanotic, which is blue? It could be yellow, which is a liver, caused by a liver condition. Temperature, is it hot? Is it cool? Is it normal? Condition, is it dry? Is it wet? Is it diaphoretic, which is sweaty? We got to check all those things. So here's the couple of examples of checking for carotid pulse here on the left, and then a radial pulse here on the right. Here's our descriptions of skin color. Pale, whitish, indicating decreased circulation to that part of the body or to all of the body. So pale skin is usually an indication of some type of shock or hypoperfusion, which means that the blood isn't circulating to all the parts correctly, and so it doesn't have the correct color. Flushed is red, or indicating excess circulation in that part of the body. Blue, like I said, cyanotic, indicating lack of oxygen, possible airway problems. Yellow is liver problems. It's also called jaundice. With those people, you might also see the whites of their eyes might be really yellow as well. And then normal for that person. Now, people of color, you can see like an ashy color on some black people when they're in shock and they have hypoperfusion. Other places we can look at the fingernail beds, the whites of the eyes, or the palm of the hand, or even inside the mouth. Do the gums and oral parts look pink like they're supposed to? And then the last part of our primary assessment is to update the responding EMS unit. So you were the first on scene, you got all this good information, now we need to let the responding EMS units know. We need to let them know age, sex, patients, any chief complaints. Are they complaining of chest pain? Are they complaining of leg pain because they have a broken leg? If it's an unconscious patient, the chief complaint is generally unconsciousness. We also want to let them know the status of our airway, breathing, and circulation. We want to try and perform all 4 of these steps as quickly as we can, as quickly as we make contact with the patient. So as soon as we get in contact with that patient, we want to be doing that really quick primary assessment, getting all that information so that we can get it out to the responding units. Next part of our patient assessment is going to be history taking. Now, if we're on a trauma with a lone passenger or lone driver, nobody knows him, you might not be able to get any history. So sometimes you can't get it. If you can, we need to do the best to get as much information from these patients as we can. So we need to talk to them about their chief complaint. Chief complaint is going to be the patient's biggest concern, their biggest problem. The injury that's causing him the greatest pain, or whatever's going on. Maybe with medical it can be, I can't breathe. So our chief complaint is going to be breathing distress. With a diabetic patient, maybe their blood sugar was low, so it's going to be hypoglycemia. Once again, like I said, with trauma patient or unconscious patients, their biggest complaint is going to be that they're unconscious. So we need to investigate it, but we can't allow the conscious patient's comments to distract you. So just because they're saying that, I'm having chest pain, we still need to do a thorough assessment to make sure there's nothing else going on. The purpose of obtaining a history is to gather a systemic account of past medical conditions, illnesses, and injuries. What existing stuff do they already have going on that we need to know about? It helps us determine the events leading up to the present medical situation, determines the signs and symptoms of the current condition. Signs would be something that the patient something about the patient that you can feel or see for yourself. That's a sign. A symptom is something the patient tells you. My back hurts. So you can't see that their back hurts unless, they have a major trauma to their back. You can't see that their back hurts. So that would be a symptom. I think I'm going to vomit. You can't see or feel that they might vomit. So that's a symptom. When getting a history, we need to question the patient in a clear and systematic manner. We need to learn relevant facts, including any serious injuries they might have had, illnesses, or surgeries. Do they have a list of their medications? Can they tell you their medications? That also includes over-the-counter medicines and herbal medicines they might be taking. Do they have any allergies to medications, foods, or seasonal allergies? If we have a patient whose airways, they're telling you, I can't breathe, and then we find out that, they had like a peanut allergy, that kind of gives us more information. It helps us determine, hey, maybe they got into some peanuts, and that's what's going on here, so that's how we need to address it. So to help get that information, we use what's called a sample history. This is that systematic history taking that we talked about. This is not everybody, but most people use this sample history to get information. Like it says here, it provides a framework so that we can ask further questions of the patient. We need to ask the patient one question at a time. We need to listen carefully to what they say and use good eye contact. If the patient is unconscious or senile, maybe there's a family member or friend or somebody knows them that can help us. And then we need to communicate this information to the other EMS personnel. So here's our signs and symptoms, here's our sample history. Includes signs and symptoms. This is the reason that they were called, that EMS was called. Allergies, any allergies they might have to medications, food, seasonal. Medications, what medications do they take? Past pertinent medical history. This is maybe we have a chest pain patient that has a history of chest pain. Can we help them with their nitroglycerin or whatever? Last oral intake, when was the last time they had anything to eat and drink? And what it was? And then events associated or leading up to this illness or injury. So this will help us put the puzzle together to help get us more information. This sample history is, you guys will be expected to know what sample stands for. So make sure we know that, just like we talked about AVPU earlier. So the next part of our assessment is going to be the secondary assessment. This is done to assess any non-life-threatening conditions and is a physical examination to help locate and begin management of signs and symptoms of injury. Once again, a sign is something about the patient that you can see or feel for yourself. The symptom is something the patient tells you about his or her condition. While we're doing our assessment, we use these acronyms. You'll be expected to know these ones as well. DOTS are signs of injury. So do we see any deformities? Do we see any open injuries? Do we see any tenderness? Or do we see any swelling? And then DCAP BTLS is the one I use most often. Can we see deformities, contusions, abrasions, punctures or penetrations? Are there any burns? Is there any tenderness? Any lacerations or swelling? Our secondary assessment of the body can be done whether the patient is conscious or unconscious. We need to assume that all unconscious, injured patients have spinal injuries. So that means we need to take spinal precautions, make sure we're holding C-spine, while we're doing our assessment. Follow steps in skill drill 9-1 to perform a full body assessment. So that skill drill is on page 184, performing a secondary assessment. And we're going to go over that. We're going to start with the head. We're going to cover all parts of the scalp, the back, up the top, the sides, looking for any of those items on that DCAP BTLS list. Now, once again, this isn't the primary assessment. We're not necessarily looking for life threats. We're just looking for stuff that we might need to treat, that might be the cause of whatever the condition that's going on. Next, we come to the eyes. We're going to open the eyes, look at the pupil. We want to see if it constricts, gets bigger, what's going on with the eyes. Normal reaction for a dark area to light would be for those pupils to constrict or get smaller. You might need to use a flashlight. If they fail to react to light or they're unequal in size, this is important, and it needs to be informed to your responding EMS agent. Next, we're going to go to the nose. We're going to look for any, once again, DCAP BTLS. Is there any blood or fluid coming from the nose? For patients with burns, you might want to look for soot up in there. That could be an indication of some type of airway compromise. Then we move to the mouth. So we should have already taken a look at the mouth when we did the airway. We want to recheck it again, looking for any other objects, food, teeth, vomitus, dentures, gum, chewing tobacco, stuff like that. Anything we find, we need to carefully clean away so nothing can get aspirated. That's when foreign objects get into the lungs and cause problems. In your book, it says to use your sense of smell to determine whether any unusual odors are present. With some diabetic patients who are unconscious, they might have a fruity, their breath might smell really sweet. This is something that you should note. You can also note alcohol, the smell of alcohol on their breath. So after we've checked the mouth, that kind of concludes everything. We did the head, we came down the sides, we checked the jaw, we checked the bones around the eyes. We need to look in the ears for any blood or cerebral spinal fluid. Then we move on to the neck. Here we're looking for, once again, any DCAP BTLS. Do we see distended neck veins? This could be an indication of heart conditions or trauma to the chest. We're looking for that stoma. Remember that hole in the throat, the neck, the throat right there, where they draw in breath because they had, usually it's because of cancer or something like that, but they have a hole in their neck. We need to note if that's something that's going on. Because if it's blocked or something like that, that's our airway and breathing right there. We need to make sure that's all taken care of. So after the neck, we're going to move down. We're going to check the clavicles, the collarbones, move into their chest. We're going to, if they're conscious, we're going to ask them to take a deep breath. See if they feel any pain upon inhalation or exhalation. Note whether they take that breath with difficulty or not. We're going to look and listen for signs of difficult breathing, coughing, wheezing, foaming at the mouth, stuff like that. We want to look at both sides of the chest. We want to make sure that it rises and deflates as one unit. If we see one side go up and one side go down, That's important findings that we need to address. It's called a flail chest, and it happens from multiple rib fractures. We want to run our hands all over that chest just to make sure that there's nothing. Once again, decap BTLS. Moving down, we come down to the abdomen. This is the stomach and groin area. We want to look for any signs of distension, which is expansion. Does it look abnormally large? Is there any external bleeding? Is there any penetrating injuries? Do we have anything stuck in it? Or is there anything sticking out? If they got stabbed with a serrated knife, sometimes it'll hook on to some of those intestines and pull it out. Or do we have any intestines or other bits hanging out? So once again, we talked about distension. This is a swelling. Could be a sign of abdominal injury. Abdomen should usually be soft and non-tender. If it's really rigid, if it's hard to push on, that's something we need to know. So we've moved from the abdomen down into the groin area. Do we know any urine or feces? These are important information. Did this patient have a seizure? If so, they were incontinent. It's important findings. Next, we're going to move to the pelvis. First, we want to look for any signs of bruising, bleeding, or swelling. If nothing is reported by the patient, we need to gently place on the pelvic bones. We want to push in from the sides and down. Do we know any movement, any crepitus? Crepitus is crunching. Do we know any crunching sounds? What is it, stable or unstable? So now we got to check the back. If we have a trauma patient, we're holding C-spine on them, we're stabilizing that neck. We want to keep that neck in line with the body. So we're going to use a couple people to log roll the patient onto their side, keeping that neck straight and in line. We're going to check the back, both sides, making sure there's nothing different about either side. Remember, some people have humpbacks. You might note that. Older people might have them. There's also people with scoliosis, and their spine might be naturally curved like that. Generally, most people are nice and straight. We need to step down each bits of that spinal column, make sure that we don't note any decap BTLS. Once again, we use it all the time. Then we're going to log roll that patient back onto their back. That's the time when usually, if you've gotten that far and you have a backboard available, go ahead and slide that backboard under them right then. All right, so we've checked the back. Now we move down the legs. We need to observe each one for, once again, decap BTLS. We're going to make sure there's no major bleed. Well, we should have caught major bleeds already. But is there any minor bleeds that need to be addressed? We're going to squeeze the limb on the way down, making sure that the patient doesn't show any signs of distress when we touch it. All the way down, ask them if it hurts, and does this hurt, does this hurt? Looking for broken bones, any swelling, bruising. When we get down to the feet, we want to check down there for pulses. We also want to check and make sure that they can feel us touching down there. This is called PMS, pulse and motor sensory. Just checks to make sure that they have all the nerves down there as well as their pulses. Then we come back and check the upper extremities, same way. Starting at the shoulder, looking for decap BTLS all the way down, squeezing the arm, ask them, does this hurt, does this hurt? We're going to check for pulses on both sides. and also if they can feel us touching their palms and their fingers. So that should be a head to toe. Like I said, we have a couple of labs where we'll go over this more and get a better flow for how that goes. So, exams of specific areas of the body. So if we have a patient who has sustained a non-significant mechanism of injury or responsive medical patients, we can focus our assessment on just those areas. So if we have a patient complaining of chest pain, we can focus on the chest, or their shortness of breath, we can focus on their chest and their lungs. It focuses your attention on the immediate problem, and it's based off the chief complaint. But remember, you don't want to get tunnel vision and just be going down their one issue. You want to give them a full assessment. You don't have to do a full head to toe every time, but you want to make sure if that patient's complaining of chest pain, they have a history of congestive heart failure, we want to see, do we have any swelling in the extremities? So don't get, like we talked about, don't get tunnel vision. But when you get these patients that are only complaining of the one little thing, we can do a more focused. We can look at that more than anything else. So after our secondary assessment, we need to get vital signs. Vital signs are our respirations, our pulse, our blood pressure, and our skin condition. Start with our respiratory rate. Normal resting rate for adults is 12 to 20. We need to count the patient's breath for 1 minute, and we need to check their rate and quality. So when we count the patient's breath, the way I do it is when I'm checking for a pulse, I do that for 1 minute, and then I keep holding that, and then I start watching their chest move in and out. If you tell somebody that you're checking their breathing, they have a tendency to alter how it really is. So you want to do it without them knowing it, really. Check for rate, so how fast it is, and quality. So when we talk about quality, it's, is it rapid, really fast? Is it shallow? Is it really, so instead of taking a full inhalation, they're taking these short little gasps. Or is it, so usually it's going to be rapid and shallow, so really fast, short breaths, or it could be really long and slow breaths. You can also describe them as deep, so they're taking just huge, deep breaths. Wheezing is kind of more of a lung sound that you might hear. Gasping, panting, snoring, noisy, labored. These are all qualities. And you might not have any breathing. Then you just have absent breathing. Pulses. This is our second vital sign. It indicates the speed and force of the heartbeat. Can be felt anywhere on the body where an artery passes over hard structure, such as bone. We've talked about a few of them. We have our carotid pulses in our neck, the radial pulses in our wrists. The brachial pulse is inside of the arm, between the shoulder and the elbow. We also have a posterior tibial pulse, which is located on the inner aspect of the ankle, just behind the ankle bone. So the inner aspect, so the inside there. Just like we talked about before, if it's a conscious patient, we want to take the radial pulse, so in their arm. Carotid pulses for unconscious patients. Infants, we use the brachial. In a normal adult, the resting pulse rate is 60 to 100 beats a minute. Now, people all have different rates. somebody who's physically fit, jogger, swimmer, whatever, it could be lower than that 60. So you have to take those kind of things into consideration. Now, when it gets down in the 40s or so, that's a good possibility of serious illness, and needs to be addressed. Determine the rhythm and quality. Is it regular? Is it one right after another on a good time? Is it boom, 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 boom? Or is it irregular? Is it a beat and then a pause and then a couple beats here and there? A good strong pulse can be referred to as bounding, just boom, boom, boom. A weak pulse is at times called thready. It's very hard to find. It feels really weak, and it can be called a thready pulse. Capillary refill is the ability of the circulatory system to return blood to the capillary vessels. It is checked in the fingers. You squeeze the patient's nail bed between your thumb and forefinger until it looks pale. You release it, count to 2, and the color should return. This is an indication of normal capillary refill. It means that the heart is moving blood correctly and that they're getting the correct oxygen out to their capillaries and then taking the waste products back. Some things that can alter that would be a significant blood loss or cold. If you're out in the cold, it can be delayed. So next is going to be blood pressure. This is the pressure. So systolic pressure is going to be the force that's exerted on the walls of the arteries as the heart contracts. So when it pushes the blood out, this is how much force it's putting on the walls of those arteries. And then the diastolic pressure is the pressure during the relaxation phase of the heart. Hypertension or high blood pressure exists when the blood pressure remains greater than 140/90 millimeters of mercury. That's how blood pressures are measured, is in millimeters of mercury. Hypertension, usually most people know if they have hypertension or not. These are things that need to be treated by their physician. Hypotension, or low blood pressure, exists when that systolic blood pressure is less than 90. So something's happened to the body. The heart cannot push hard enough to get the blood out to the extremities. It can't exert that force on the walls of the arteries. This is usually we consider 90 or 90 systolic or below somebody in hypertension. These people usually in serious trouble. We need to treat them for shock. You might find that they're also cold, clammy, pale skin, dizziness. That's when we need to start treating for shock, keeping them warm, finding any bleeds that might need to be addressed. To check the blood pressure, we can do it by palpation. We can feel it, or we can listen to it. That's the usual way that we do it. When you go to the doctor, that's the way they most likely have done it, is by listening to it. So the next vital sign will be skin condition. We already should have checked this when we did our primary. We're looking for skin color, temp, and condition or moisture level. Our normal body temperature is about 98.6. We can check for a temperature by holding the back of our hand to patient's forehead to check for it. Normal skin conditions are described as warm, pink, and dry. Now, that might be different. We talked about the other ones, the pale, cyanotic, jaundiced. Those are all things that we need to remember. Then we move into pupil size and reactivity. We should have looked at this in our secondary. We need to examine each eye to detect for signs of head injury, stroke, or drug overdose. Here you can see a couple different examples. This would be normal eyes here on the left. These are dilated, enlarged in the middle, and then you can see they're very small. And these are all in the same light conditions. So when you check for pupils, remember that we're going to kind of cover their eyes for a minute, then open them and shine a light, and we should see some reaction. And they should be the same. Both sides should be the same. If one's really big and one's really small, that's something that you need to know and let the other EMS responders know about. So here we have the pupils of unequal size can indicate a stroke or injury to the brain. Pupils may remain constricted in a person who's taking narcotics, so pain medications or heroin, opioids, stuff like that. Dilated pupils can indicate a relaxed or unconscious state. And then once again, we're going to check our level of responsiveness. We need to observe and note any changes that have occurred between when we first checked them and now that we're doing our set of vital signs, and we're going to use that AVPU scale. So if we've made it all the way through all that and we still don't have an ambulance or somebody else on scene, we need to continue reassessing the patient. So we need to repeat the primary assessment. We need to recheck the patient's level of responsiveness and ABCs. We want to make sure that we need to check the responsiveness to see if there's any changes, and then we need to check the ABCs to make sure that we're maintaining that airway, that breathing, that circulation. If we stopped a major bleed, is that treatment still working? Or did something happen and it's now bleeding out again? Need to continue to observe the patient's skin color and condition. Did anything that we do change that? Were they pale and cool and clammy? We started treating them. We stopped that bleed. We got started breathing for them. We were keeping them warm, and now they're looking better. That's stuff that we need to observe. Reassess the patient's blood pressure. If this is a conscious patient and we're treating something, we need to reassess the chief complaint. Did anything we do make it better? We have that patient with chest pain. We help them with their nitro. Did that help? Are you still experiencing that chest pain? Is it the same chest pain? Is it worse? Is it better? And that'll also tell us if we need to change anything that we're doing. So like I said, we identify and treat any changes in the patient's condition. Reassess the patient. We want to reassess stable patients every 15 minutes. If they are unstable, we need to repeat those reassessments every 5 minutes. And then after all that work we did, and the ambulance shows up, we need to provide a handoff report. This is going to include the age and sex of the patient, history of the incident, so what happened. We need to inform them of the patient's chief complaint, level of responsiveness, how we found them. If this was a car wreck and there was an ejection of the patient, did we find them face down in the dirt? Did we find them hanging in a tree? How did we find that patient? We need to report the status of the vital signs. So did our vital signs get better? Did they get worse? Or maybe we were only able to take one, and that's what you give them. Any results of the secondary patient assessment? Any pertinent medical conditions that we obtained using the sample format, And then any interventions that we provided, and how did the patient respond to those interventions. So a word about medical and trauma patients. So these are generally the two classifications of patients. We either have a sick patient or we have an injured patient. The patient assessment sequence can be used to examine patients who have experienced illness, trauma, or both. You know, maybe they got in a car wreck because they were having a heart attack. Who knows? When examining medical patients, we follow that basic assessment sequence, the one that we just went through. When caring for a trauma patient, you can perform the secondary assessment before taking the medical history. Once again, always avoid jumping to conclusions. So, quick summary. A quick patient assessment consists of 5 steps. We're going to perform a scene size-up, perform a primary assessment, obtain a patient's medical history, perform a secondary assessment, and provide reassessment. Scene size-up is a general overview of the incident and its surroundings. So we're making sure we have all our correct PPE on, and we're observing the scene to get an idea of how many patients, do I need additional resources, was this a trauma, do I need to be holding C-spine, that kind of stuff. In our primary assessment, we're going to determine and correct any life-threatening conditions. Remember, the primary assessment is to treat and correct life-threatening conditions. This is going to give us a general impression of the patient, assess responsiveness, rapidly scan the ABCs, airway, breathing, circulation, and then we're going to quickly call a report to any responding EMS units. Then we're going to get a medical history, provides an account of the patient's past medical conditions, illnesses, injuries, determines the signs and symptoms of the current condition. Our secondary assessment of the patient consists of an assessment of the entire body and is used to treat non-life-threatening conditions. Then we get into reassessment. Patient is stable. We're going to repeat those vital signs every 15 minutes. Unstable patients, vital signs happen every 5 minutes. And then we need to provide a concise and accurate handoff report to EMS. Quick review, some review questions. Which of the following steps might be performed during the scene size-up? So this is the first thing we do when we get on scene. So are we going to assess vital signs using appropriate monitoring devices? Forming a general impression of the patient? Notifying dispatch to send fire personnel? And performing a full body scan? We know that we assess vital signs during our secondary assessment. Our general impression happens during our primary assessment, and the full body scan is going to happen during our secondary. So notifying dispatch to send fire personnel would be our answer here. 2, the goal of the primary assessment is to quickly diagnose the patient's condition, determine the need to perform a full body assessment, determine the number of patients, or identify and treat life threats. So we know we don't diagnose conditions. Determine the need to perform a full body assessment. Full body assessment we know is going to happen in our secondary assessment. Determine the number of patients. That should have already happened in our scene size-up. So the only one left is D, which is identify and treat life threats. There you go. 3, after performing a primary assessment and treating any immediate life threats, you should next determine the priority of patient care and transport, reassess the patient, recheck your interventions, or promptly transport the patient to the closest hospital. So looking at them, we know that we don't reassess the patient until the end, and that's also when we're going to recheck interventions. We don't transport patients to hospitals, so that leaves determine the priority of patient care and transport. All right, guys, that was Chapter 9, Patient Assessment. We'll see you on the next one.